Hello and welcome to my masterclass on West syndrome. I'm Dr. Tekira, consultant pediatrician with expertise in epilepsy, working at Lieutenant Dunstable University Hospital. I'm going to talk on West syndrome, which is a rare and severe form of epilepsy that occurs in infants, which should not be misdiagnosed. This masterclass is meant to enlighten all medical professionals dealing with children. Either you could be a GP, any professional, pediatrician, or even a medical student. It gives knowledge and skill to recognize infantile spasms, differentiate it from other conditions. It gives a skill to recognize it early and best evidence-based treatments. I'm going to take you through this journey of what this condition is, the history behind it, clinical features, investigative workup, the chances of misdiagnosis, how we can minimize them, newer strategies of management, and what it does in terms of a prognosis, and summarize at the end with giving references to read further. West syndrome is an age-dependent expression of a damaged brain. International League Against Epilepsy revised the classification in 2010 and designates West syndrome as an electroclinical syndrome with onset in infancy. An epileptic spasm is a type of seizure. It's one of the severest forms of epilepsies with very bad prognosis. It's a triad consisting of a type of epilepsy called infantile spasms, developmental delay or regression, typical EEG changes named Hips arrhythmia. It was identified by Dr. West in his own son in 1841. However, it has not been recognized as a syndrome until 1960, and effective treatments were recognized in 1980s and 90s, and we have got better treatment strategies in millennium. We should recognize this early because delay in treatment could cause severe developmental regression. This is a typical type of seizure in which child goes into a cluster of spasms, each one lasting for 1 to 3 seconds, and 5 to 10 of such spasms occur in one cluster, and these clusters can happen several times in a day, typically 2 to 3 times. It's generally seen in ages between 3 and 7 months. Incidence is about 1 to 3 per 10,000 children. As you see, it's an abrupt flexion of the head, abduction of the arms, and flexion of the trunk. Other types also could happen, such as extension of the trunk following a flexion. Usually they're symmetrical, and as mentioned, they occur in clusters. It could occur at any time of the day, usually after waking or just after falling asleep. It is believed to reflect an abnormal interactions between the cortex and brainstem structures that produces these types of spasms. It's also believed that excessive secretion of corticotrophin-releasing hormone causes these seizures. Hence, the treatments with steroids and ACTH are very effective. It could be caused by multiple etiological factors such as structural brain defects, metabolic causes, damage to the brain that occurred before birth and after birth, such as intrauterine infections or postnatal infections, and severe asphyxia. Genetic causes also found in many cases. If we find an identifiable cause, then we call it symptomatic. However, if we think that still there is an underlying cause but still could not recognize, it could be called cryptogenic. Whereas if we find no cause at all, it is called idiopathic. When we are evaluating a child with infantile spasms, we should take a careful history of antenatal events at the time of birth, whether there was any birth asphyxia, and development since birth, and also since onset of seizures. When we examine the child, we need to measure the head size because a small head or a large head may point to an underlying structural brain abnormality. Examine the eyes for retinal phacomata identified in some of the neurocutaneous conditions such as tuberous sclerosis and Sturge-Weber syndrome. Examination of skin points to, again, diagnosis such as hypopigmented lesions in tuberous sclerosis. When we work up for the condition, the main aim is to confirm this West syndrome, identify the underlying cause, and identify typical conditions such as tuberous sclerosis, which could actually give a different way of management rather than a generalized management like any other condition. So the laboratory investigations could include routine bloods, including electrolytes, bone profile, magnesium. We need to rule out infection by doing inflammatory markers. Sometimes lumbar puncture may be necessary. Metabolic tests are only done in special cases where we are strongly suspecting metabolic cause, such as lactate, ammonia, amino acids, urinary organic acids, and biotinidase. When it comes to imaging of the brain, MRI is the best. However, sometimes we do CT to rule out tuberous sclerosis if MRI is not available immediately. EEG specifically gives you diagnosis. As shown here, this is a normal EEG where you can see slow wave forms in a regular pattern in the 20-lead EEG. Whereas in West syndrome, you can see this high to extremely high voltage polymorphic slow waves superimposed with multifocal spikes and wave discharges. This pattern is called hypsarrhythmia, otherwise a chaotic EEG. It's an interictal. If we find none of this pattern, you may have to repeat with a sleep deprivation, which is more sensitive. Sometimes we may get confused with simple conditions like colic, gastroesophageal reflux, excessive startles, and exaggerated motor reflexes. I have had a case which was misdiagnosed for 3 months before sent to secondary care. The other epilepsies such as benign myoclonus of early infancy, benign neonatal sleep myoclonus, benign and severe myoclonic epilepsies can also be possible, but we can distinguish by doing an appropriate EEG. We have evolved in a long history of trial and errors, and now we established good treatments. National and international multicenter trials have happened, such as United Kingdom Infantile Spasm Study and International Collaborative Infantile Spasm Study. There are many treatments to start with: steroids, prednisolone, and ACTH, vigabatrin, used to be tried individually, but nowadays a combination treatment following international trials is the best evidence-based now. We can refer to the local and regional practice guidelines. I'm not going to go through full treatment protocols as they're available elsewhere. Unfortunately, West syndrome carries very bad prognosis. However, some better prognostic factors are if there is no cause found, such as an idiopathic West syndrome, if the age of onset is very early, and if the atypical spasms and partial seizures are not seen, that carries better prognosis. Asymmetrical EEG abnormalities is also a bad prognostic factor. Response to treatment is better seen in those with idiopathic than those with asymptomatic causes, such as structural brain abnormalities. As it progresses, the condition may evolve into a different type of epilepsy syndrome called Lennox-Gastaut syndrome in up to 50% of cases. deaths are reported between 5 and 30% in various studies. Most of these children end up with a learning disability, such as autism. So in summary, it is a triad of a typical epileptic seizure called infantile spasm, intellectual disability, and typical EEG changes. It's a severest form of epilepsy with poor prognosis. Early recognition is very important in terms of achieving good prognosis. Treatment with the combination drugs such as steroids and vigabatrin are useful. Do not misdiagnose or confuse with benign conditions. I'm giving some latest references, of which UpToDate website provides you a very evidence-based information. Thank you very much for listening.